The October AKT feedback is really important because you've got a couple of weeks to go for the January AKT if you're sitting it, and so that's a really useful way to really sort of hone down, identify what's on there. If you're already doing this, we're sort of well within revision mode, I would strongly recommend that you go and have a look at the July AKT feedback. I've already done a full video on there. You've got the QR code there, or you can go onto the Doc Support YouTube channel. Please feel free to subscribe whilst you're there. It really helps out. But that is about a 30-40 minute video of what's there as well. Okay, so the AKT feedback report then really covers areas that candidates did really badly. It's useful to know about this because, and you'll see certain themes coming through, guess what? They crop up on the next exam. So if you're over this next couple of weeks, you're really struggling with what to do and what to cover, then actually this is a really good way to sort of just cover it and give you a couple of nudges from that perspective. So what we're going to talk about is prescribing, confidentiality, children's health, and there's quite a big thing to cover from this. And then lastly, neurology. Now we'll kick off with prescribing. So this is what it said on here. So prescribing is a regular area on which we provide feedback. So that's a huge bit, meaning that prescribing and what's going on is always going to sort of crop up on the AKT. So in AKT 57, so that's October 25, candidates struggled with knowledge of side effects and medications prescribed for long-term conditions. Candidates should consider common and/or important side effects for frequently prescribed medications. So absolute game changer in terms of information that we're giving and sort of passing out from that way. Okay, so what we can look at from that perspective is, where do we go with this? Okay, now, if you look at the July one, I actually used similar slides because they talked about prescribing in the elderly. And so the two are hand in glove in terms of, if you're prescribing long-term medications, guess what? They're generally going to be for an elderly population. So I think it's worthwhile thinking about your anticholinergic burden, DMARDs, and also common medications where you need to drop in renal function, okay? Because that's what cropped up on the July feedback and is well worth reflecting upon. So your anticholinergic side effects, and so sort of thinking about, have you got too much? So are they getting drowsy, restless, memory loss? Are they getting cognitive impairment? Are they tachycardic with this? Okay. And are you getting your pupillary dilatations? Are they getting these odd sort of like nausea and vomiting, constipation, and also any urinary symptoms as well as an anticholinergic burden? There are certain medications that will put you more at risk of them. Okay, and you just sort of think that what will happen is that you get one or two of these medications that sort of build up and add up, and it's worth being mindful of in your elderly population of what they are. And so when presented with a list that you think like, right, hang on a second, I know where these are going and know what to happen from that perspective. DMARDs are tricky. It's tricky. I'm a GP partner, and none of the doctors touch DMARDs, as in like we don't monitor them, we don't expect them, as in like on our day-to-day we have pharmacists and a nurse practitioner who keep a very close eye on this, and they do a far better job than me. The problem is then for the AKT is that DMARDs and certain medications is a really common and a really good question to ask. Okay, so really looking at what bloods to take them for what medication, and also what you're looking out for. So what specific side effect, why are you taking that full blood count, what you're looking at from that perspective. CKS have got a really good DMARDs monitoring bit. I've left the web link up there, but make sure that you go through the common sort of medications and in terms of what you're doing and where you're going from that perspective. The ones that I would definitely make sure that you're aware of, because there's a massive list of there, is your common ones. So methotrexate has got to be up there. Azathioprine, cyclosporin, hydroxychloroquine, and then tacrolimus as well. Is if you've got limited amount of time, which you have, just make sure that on those 5 medications that you really know them inside out and that you're absolutely happy with them from that perspective. Moving on to renal function, this list is not exhaustive, but think about whether, common medications where you might need to drop down the renal function or drop down the dosing because of renal function. So things such as metformin, where the eGFR is less than 30, your gliflosins, and also your NOACs as well. So it should be DOAC, I do apologize for that. So things like Apixaban, avoid if creatinine clearance is less than 15, and you can half the dose if creatinine clearance is even lower than that. So prescribing, top tip, speak to your trainer if you're prepping over this next bit at your debrief. I'm assuming you're going to debrief after every clinical session. For every medication that you prescribe, get into the habit of revising two of the side effects or the common side effects for this. Because if you go back to the initial feedback report, they're saying about common medications. Guess what? If you're in medical practice and you're currently on general practice at the moment, which I expect you to be if you're sitting your AKT, then actually you're going to be the things that you're prescribing by definition are going to be common medications and common side effects. If your trainer's on board, I appreciate everyone's got different trainers, different personalities, that actually your trainer should be quizzing you on this as well. And whether you're doing a random case analysis, start asking them saying like, look, sit my AKT, I know prescribers are going to crop up. Can you quiz me on common side effects for every medication that I prescribe? Just as an idea to help you build your knowledge of this. So moving on, confidentiality. Guidance around confidentiality was an area that caused problems for same candidates in AKT 57. Candidates are reminded that this is an important part of it being a GP for which GMC provides detailed guidance. Soon as it's mentioned GMC, you're talking about duties of a doctor. Okay, so you'll see at the bottom it says the banner, the other 20%. I run an online course, which I'll leave all the links to at the end, with one of the specifically aiming at the statistics and the admin element of the AKT, for which this firmly falls down. What I've done is I've stripped down a shortened version of the module, and we're going to talk through this. Okay, so duties of a doctor really for GMC covers, you need to know broadly three areas. One, actually what is on the duties of doctor, and then applying it in two areas. One, social media, because that has cropped up on previous AKTs. And then the second part is your appraisal. So your ongoing medical education and your ongoing proof that you are a competent doctor. And it's worthwhile being mindful of those three areas and how they differ. So, for example, your appraisal and revalidation is very similar to the portfolio that you're running already, but it's not as intense. And knowing what you need to do and in what frequency is really useful in terms of being able to sort of push forward, as it's a great AKT question. For example, how often should you do a patient feedback? How often should you get colleague feedback for that part? GMC, what can you post on Facebook? What can you put out on YouTube that keeps you safe within that? And they've got separate guidance on this. So your duties of a doctor cover four broad areas, okay? So knowledge, skills and performance, safety and quality, communication, partnership and teamwork, and then lastly, maintaining trust. So your communication, partnership and teamwork, which we're going to sort of focus on because this is where it sort of falls down to, is treating patients as individuals and respecting their dignity and treat patients politely and considerately. And then the second part of this is respecting patients' right to privacy and confidentiality. So that's what they're talking about. But we can sort of apply this a bit further. So when thinking about sort of working with partnerships and with patients, we're sort of saying that we need to listen to and respond to their concerns and preferences, and also give patients the information they want or need in a way they can understand. So factoring in language barriers, maybe a disability of some sort where they can't understand or can't appreciate it. And respect patients' right to reach decisions with you about their treatment of care. Even if they don't agree with it, as in you personally, they still have a right that you've got to maintain for the patients being mindful of it. And also you need to support the patients in caring for themselves to improve and maintain their health. So that ongoing preventative medicine. From an appraisal point of view, when you're communicating in partnership with patients, so it's reflecting on any comments, compliments or complaints, and also providing patient feedback questionnaire at least every 5 years. So it's not like you have to do where it seems to be every other second you're getting patient feedback, it's once every 5 years. Admittedly, the actual form itself looks very, very similar. Presenting yourself on social media, it doesn't, so when you say social media, it can be anything. So it can be as simple as a blog post, it could be Facebook, YouTube, X, LinkedIn, anywhere where you're interacting online. It still sort of covers under that broad banner of social media. So it's not all negative, and actually the GMC reflect this, that, and you'll see a lot of social media doctors who do really well at this by engaging with people in a public health and policy discussion. So sort of like actually enlightening the public without it being just in sort of a doctor setting or in a GP practice, establishing national and international professional networks. Like, how many American doctors have you seen, say, for example, posting videos, and also facilitating patients' access to information. Now, going back to the confidentiality bit, you've got to be mindful though at patients, then, if you're putting yourself out there, that you're at risk of patients contacting you. And you must, if that happens, direct them to their usual place of care. You also get into that tricky position, say, if someone says, like, can I show you this rash? Is that, say, for example, none of these social media sites are on a UK server, hence why I've got this picture of this, big black box meant to represent the server room. As soon as it's not in the UK, that means that patient data is potentially stored outside of the UK, and you're at risk of GDPR and all that bad stuff from that way. What the GMC also reflect upon is that it blurs the boundaries. Like, you are entitled to a private life. Absolutely. You've got to look after yourself so that if patients are contacting you and it's 7 o'clock at night, you're trying to enjoy your life with your family, and they're going to put a direct sort of that blurs that boundary from that aspect. The other bit as well, we've talked about where the servers are, is that what you won't realize, or you may realize depending on your technical knowledge, is that a lot of the photos, etc., will put a date time stamp and a location stamp on them automatically. And it's one of those where you think about like a busy sort of pre-hospital care doctor saying that, oh, I've just attended a really bad crash, 3 people died, for example. Then actually it wouldn't take too much if they can see the location, see the time, that actually a family member might be able to sort of recognize that. I've seen it, and there was a very interesting discussion with the NPS where on a doctors group, so on a doctors forum, that they were playing the highest PSA number that you've seen. And someone turned around and saying, I've seen someone with, a crazy number. It was in the 600 odds. Unbeknownst to them, their daughter was a fellow doctor on that same group. And because it was an odd number, and because once you've got the doctor's name, she actually located where that doctor was at that same practice that her dad was registered at, and put in a formal complaint against them. So it's thinking about that wider picture and being aware of that even if you're online, you're still potentially sharing patient information, and they've got to maintain that level of confidentiality. So moving forward in terms of your colleague interaction, and this is the big reason why I came off X, is because actually you've got to be very mindful that even if you're communicating on social media, that actually you are held to the same standards as if you are communicating to them directly. Okay. So for example, there was a massive sort of jump on physician associates, a lot of negative rhetoric, without it being a professional discussion, more of just a name and shame, which is not helpful to anyone in terms of developing on the conversation. The issue then with that is that you are at risk and at breach of GMC contract by insulting other colleagues, and not putting it as a professional statement. Okay. And again, just to highlight that again, that data is not safely stored. What would be great as a professional development, if you're working on WhatsApp, that's technically part of the social media bit, is that if you've got a professional WhatsApp group, which some of you may or may not do, that is not secured data to the level of GDPR. Okay, so if you're saying like, oh, I've got this case, blah, 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 and you're trying to get your boss to help out, then actually that's not safe and not suitable under the NHS. And it should be put onto a separate system, PANDO being one that is worth doing. If you're looking for a QIA project, I think that would be a brilliant one to do, that you've changed it team, all your information management and governance, you pushed it across to there. Okay. Another one to think about, which again, the RCGP highlight that they can put any question that is related to current guidance or something that's new in the media, and artificial intelligence is everywhere in terms of being talked about at the moment. It's highlighted on the NHS 10-year plan, but the big issue is like, is it safe to use? And that falls into patient confidentiality being one, i.e., where is the data stored? And it might be worth about having just been mindful in these last couple of weeks of, are you being brushed upon the use of digital products in primary care? Have a look at EGP Learning. So Hussein Gandhi is a phenomenal YouTuber, and has got a load of information and a couple of really good videos about use of AI in primary care, and also what certain bits that you need to do. It'd be worth then, off the back of that, thinking about DCB 0160, which is a risk assessment that you need to implement within primary care for AI products to be used, and also a DPIA, which is Data Protection Impact Assessment, because that then falls into about patient confidentiality. Okay, so just to highlight that this was from the course that I've run, online course that's completely digital, e-learning course. It's got 16 modules, and I'll go through it to the end. And I've just stripped out a shortened version of the duties of doctor. If you want to go and have a look at it, it's docsport.co.uk/RCGP AKT course. I've got a discount code which I'll sort of give at the end of this talk. So Paediatrics is a huge chunky one, okay, which we'll sort of go through from that perspective, that they've given a load of information and gumph about it. So firstly, candidates struggled with presentations of cancer in children. This included common presentations as well as rare but important scenarios. Early recognition of cancer in children is an important area which we'll continue to test. Huge red flag, means go and revise cancer in children. Similarly, acute illness in children is an important topic which caused difficulty in AKT 57. Finally, safeguarding was variable, with some candidates doing well in some questions and less well in others. Candidates are reminded to the recognition of common safeguarding presentations is an essential part of primary care. Couldn't agree more. And I will touch upon, so this really breaks down into sort of three areas. So childhood cancer, thankfully rare, but again, really serious, and you know what you need to do. If you're not used to dealing with sick children, what to look out for, it'll be well worth looking at spotting the sick child, and I'll leave a link to it. I've got a slide on it, and also safeguarding as well. I'll touch more upon this as well, what I think actually will fit into a better way of identifying it. So childhood cancer is thankfully rare, okay? 5% of all new cancer diagnoses in the UK, with 1 in 500 children will develop cancer by the age of 14. Leukemia, specifically ALL, is the most common type, and I've got sort of a couple of slides on that. Childrenwithcancer.org.uk gives some really good sort of baseline information. I'll certainly go and have a look at that and make sure you revise. ALL, so sort of here's a list of sort of things that they may present at, in terms of they looking pale, feeling very tired, bruising or bleeding easily for no reason, fever, night sweats, recurrent infections, which is tricky. If you looked at the feedback report, they're talking about acute illness, and I'm wondering whether there was a question that stumped a couple of people where there was something like they had recurrent infections. You know, is it just a normal viral illness, or did they try and fob them off with something else? Swollen lymph nodes, bone pain, loss of appetite, swollen abdomen, and swelling of one or both testicles. So what I would expect, that question working backwards, is that you had an initial presentation that could have easily been just an acute viral illness, but then actually looking at it, they put a couple more of these red flags in. Okay, so this is a really good article that I found that I would make sure that you go and have a look at. It's all free. So just Google clinical presentations of childhood leukemia, a systematic review and meta-analysis by Rachel Clark et al. Basically. But if you type in that, you should be able to find it. Free article. I've just snipped out a couple of really key points because that would feed into an AKT style question quite happily. So what is already known, serious illnesses such as cancer are rare in children in primary care and are easily missed. Okay, so we need to know it. Leukemia is the most common cancer of childhood. Okay, so we need to, if you're going to read about one cancer alone, this one is the need to know. Okay, so over 50% of children with leukemia have palpable livers, spleen, pallor, fever or bruising on diagnosis. Okay, so you need to, if you've got a question and they chuck any of those into it, you need to be thinking, is this ALL? Abdominal symptoms are not typically included in national cancer guidance for identifying children with leukemia, yet are present in about 30% of cases. Anorexia, weight loss, abdominal pain being about 12% and distension 11%. Okay, so you can see it's a lot smaller, but if you get it, if I was going to write a question, I would put all of those symptoms in. Okay, so they've got viral illness, they've got night sweats, a couple of lumps, abdominal swelling, and then so it's really, really clear. Okay, important common musculoskeletal and bleeding are often omitted, such as mucosal bleeding, so bleeding from the gums, anywhere else, joint pain, and limp. Okay, so just be mindful of that. Lastly, I'm not going to go into it deep. If you haven't heard of this website, Spotting the Sick Child, it goes through a full assessment of how to, does exactly what it says on the tin, assess and sort of reassure with regards to sick children. Regardless of if you're sitting the AKT or not, make that one of your PDPs that you're going to go onto the Spotting of the Sick Child and just work through their resources. It is excellent, and I would strongly recommend. I've done a pediatric rotation as part of my GP training, and that was bleated about all the time, quite rightly so. So safeguarding will fall into sort of four broad areas. Okay, physical abuse, sexual abuse, emotional abuse, and neglect. It is worthwhile thinking about what are the signs and symptoms of each of those. So think about neglect with the child not brought policy, that actually that could reflect medical neglect. Okay, thinking about also physical abuse of odd bruising in a non-mobile child, which may present into primary care, circular burns, which could be cigarette burns, and also potentially signs of sexual abuse with over-sexualization of preteens, any sort of bruising to the inner thigh, etc., etc. Go and make sure that a lot of e-learning for health, the modules there, the level 1 and level 2 are for free. And so I'd recommend that you sort of have a look at those and make sure that you're happy with those prior to going forward. Okay. I would broaden this out and having a look at, because I spend a bit of time looking at the AKT feedback reports, that often what is missed is, and what needs to be revised, is your mandated training. I'm not talking about your computer monitor, are you set up, have you got an appropriate position, but what I am talking about is the medical mandated training. So you're safeguarding both child and adult, go and have a look at that. BLS algorithm, your choking algorithm, okay, those ones. Anaphylaxis, including drug dosing. I sat the AKT twice. Anaphylaxis drug dosing was on both of my AKTs. And also think about your emergencies, for example, your asthma attack. Think about what would you do with the central crushing chest pain, what is expected of you as a GP, okay? So just think about those, and as part of your revision for this next couple of weeks, go away and do those, okay, as part of it. Neurology. Oh my word. Right. If you're going to learn one thing, okay, so neurology and comments on neurology, I'm really sorry, have been on the past 4 or 5 of the AKT feedback reports. Okay. So neurology is again a feedback area in AKT 57. That in its alone mean that if it's been on it again and been on it previous times, guess what, ladies and gents? There's a very good chance they're going to put a neurology question in this up and coming AKT. Candidates found particular difficulty in identification of significant neurological conditions, as this is frequently a topic for feedback. Again, highlight. Come on, they're telling you the answers now. It may be worth considering this in a tutorial or study group as part of your revision. Okay, so this was again on the previous, if you look at the July AKT feedback video, I've taken the slides from there because actually it really highlights this. So what you should know: stroke, TIA, headaches, all different types of Cauda-Equina syndrome. I said what I'm hinting at is because I think they were saying about some weird and wonderful neurology, and they were talking about dizziness and progressive neurological conditions, which I think we need to sort of highlight as well, because nobody really likes revising them because they're really hard and tricky. What I mean by that is your MS, your MND, and your PSP. So these really, really tricky ones that you're like, oh, what's going on there? So with MS, you can get a multitude of symptoms, sort of looking at your optic neuritis, difficulty in swallowing, urinary symptoms, sudden change in, constipation, diarrhea, and also these odd sort of neurological tingling, changing, burning, thinking. Okay, and sort of your muscle spasms as well. It's really broad and really difficult to sort of pick up and identify, and that's why because of that, the date of initial presentation to diagnosis generally is so long. Think about MND. This is a really good sort of guide that I found in terms of, does the patient have one or more of these? So dysarthria, dysphagia, tongue fasciculations, localized weakness, cramps, And then looking at sort of respiratory symptoms with hard to explain respiratory symptoms, shortness of breath on exertion, which is such a vague term, but again could be hinting at this, combined with fatigue, early morning headache, behavioral change, emotional ability, and also is there a dementia picture as well, combined with is it progressing? Okay, so thinking about sort of like, is it asymmetrical features? Age can present at any age with MND. Okay, and are they getting factors not supporting it, which is interesting as well because it may sort of like that will be in your question chunk. Bladder or bowel involvement, predominantly sensory symptoms. Is there any double vision? So that's saying it's not supportive of it. But go away and have a look at MND is what I would do as well. PSP, lastly, sort of like think about eye movements, difficulty in control eye movements upwards, difficulty with balance whilst walking, tendency to fall backwards. PSP is also associated with an unusual shuffling gait. Okay, so again, but you've got that cross correlation with Parkinson's disease as well. Again, make sure that you sort of having a look at that. Speech and swallowing problems as well, resulting in, so have you got a question that's talking about slow slurred speech, choking or coughing whilst eating? Okay, so that's a rundown of the AKT feedback. Okay, you've got a couple of weeks left to go for your AKT. So you've got really sort of four broad areas that this one pulled up. So drug, common side effects, which is all a very, very classic and very common AKT question. Okay, confidentiality, your kid one where you're breaking down with safeguarding, childhood cancers and acute illness, and then lastly, neurology. Okay, make sure you spend a bit of time between now and then going through neurology. And please drop me an email, dave@docsupport.co.uk, if it crops up, because guess what? I think it will. Okay, fab. So we're about sort of like that's the presentation done. The other 20% is an e-learning course that I've done, which basically I've taught multiple trainees and they all come back to me and say, Dave, I struggle with the stats and the admin. Absolutely fine. I nerded out hard on it, so created this online course that's got 10 modules on stats, 6 modules on admin. As you can see here, you can read through that. If you go on the website, docsupport.co.uk, RCGP AKT course, we've got a couple of options with how long you have access to it. So each of the modules contain about a 5 to 10 minute video with an explanation text, and there's over 100 questions to help you revise this as well, which will put you in a good position. The candidates, this has been running for just shy of a year now. We've had about 30, 40 people go through this, and the people that have come back to me, they're getting about 70, 80% within these areas, which is marvelous to hear. You've got access for, depending on your time, because I'm conscious that some of you may have kids, other caring responsibilities, and so don't have a lot of time. For that, I'd recommend you go for a longer package. There's a 1 month option. If you've got a bit more time, a bit more availability, there's a week-long course and also a 48-hour access, and you get 15% off for all of the courses if you put in DocS15 for it. If you go on our website as well, go under products and ebooks. I've also written 3 ebooks as well to help you along with this. The AKT exam prep made simple is just a run through of how to revise for the exam. And just the stats and just the admin is a chunk load of questions if that's the way you work. Each of them are about £10, but then if you buy multiple books, you get 10% off for 2 books and it goes more and more. And that's that. So I'm done. I'm going to leave that up just so that you can do it from that way.